why don't we go ahead and get started? I can't say good, I'll say good day to everybody because we have a global panel and we are across time zones. My name is Pat Stone. I'm the Centennial Professor of Health Policy at Columbia School of Nursing, and I direct our Center for Health Policy, which is sponsoring this event. I'm very excited to welcome you to today's event, Global Perspectives of Policy Impact on Nurse Wellbeing. We're going to hear from our expert international panel on the existing state of nurse well-being. I'm going to hand it off to Dr. Allison Norful, an assistant professor here at the Columbia Nursing and an expert on interdisciplinary care delivery models and the impact of work environment factors on nurses. And she will have some opening remarks and introduce our panel and moderate the event. So thank you, Dr. Norful.
Thanks, Dr. Stone. Welcome, everyone. So today's panel is very timely, as you can imagine, and we are going to really focus on the profound impact of workforce and care delivery policy on nurses. You know, the nurses are the backbone of our healthcare system, and the policies that nurses interact with really shape our work environment, career pathways, and patient care responsibilities, and have far-reaching consequences. So whether through legislation or hospital regulations or federal programs, these policies influence everything from staffing ratios to professional autonomy and career advancement. Today's discussion is going to explore how workforce and care delivery policy affect nursing practice, some job satisfaction, and patients, among other outcomes related to the populations and communities that we serve. Our global panelists today, I'm delighted to have on the call. We've had the opportunity to work together for several years, and they are experts in healthcare policy, psychology, nursing leadership, and research. And together, we'll share some insights on both the challenges and the opportunities that arise from evolving regulations and systemic policy shifts. So I'm going to pass it off to my colleagues just to give a quick introduction of where they are. Dr. DePierro?
Sure. Good day to everyone as well. I'm Dr. Jonathan DePierro. I feel like an imposter in this group because I am not a nurse. I'm a clinical psychologist and associate professor of psychiatry at the Icahn School of Medicine in New York. And I run the Center for Stress, Resilience, and Personal Growth, which is a center that focuses on healthcare worker well-being at Mount Sinai. We provide lots of educational services, but also formal mental health treatment to Mount Sinai employees, their dependents, and now the public. And I do a lot of research similar to Dr. Norful on nurse mental health, workplace factors, and interventions.
Thanks so much. Dr. Castro?
Hi. Good day, everyone. I'm Erlinda. I'm a retired professor of the University of the Philippines, Baguio. But at the moment, I'm a professorial lecturer of the University of the Philippines College of Nursing in Manila. At the same time that I do get a lot of involvement with the National Association of Public Health Nurses of the Philippines, whereby I am a founding board member of that association. It's one of the newest associations. It's just 2 years old. And that I'm very much involved with the Philippine Nurses Association, which is a national organization that looks after the welfare of nurses. So we are very much into what is happening really on the ground, and that my basic involvement with PNA at the moment, aside having led it as a national president in 2019, is I continue to be the editor-in-chief of the Philippine Journal of Nursing since 2008, and preparing to pass it on to somebody else in a couple of years. Yeah, thank you, Allison.
Thank you. And Dr. Albloushi?
Hi, good day, everyone. My name is Monirah Albloushi. I'm assistant professor at the College of Nursing, King Saud University, Saudi Arabia. My background is education. So I was teaching since almost 20 years. However, I did many research regarding nursing well-being, and that was one of the research that was published last year with Allison, and I did some studies with compassion, fatigue, and other research areas regarding nurses' well-being. However, when I was doing my research, I found there are some areas that need to be investigated here. Maybe I'll discuss it later when we go through the questions. I'm happy to be here and happy to share my some background about nurses in Saudi Arabia. And I hope after our discussion we can do something or collaborate and research that enhance their well-being and quality of life.
Great, thank you all. And as Dr. Stone mentioned, I'm Allison Norful. I've had 25 years of experience in different sectors within healthcare, clinical nursing administration, as a nurse practitioner. And now today I am jointly appointed as faculty at the Columbia School of Nursing in New York and jointly appointed with New York Presbyterian Hospital as a nurse scientist. So this conversation, as I mentioned, is timely and is essential as the healthcare landscape continues to evolve. I'm really looking forward to this engaging discussion with our panelists as we explore again how policy decisions shape our profession. So let's think about first, I'd like to pose the question about what do you perceive as the most common occupational contributors to nursing burnout or to nurse well-being in your region? Monirah, do you want to start?
Okay. Honestly, I did some research and I found good resources about the key challenges that nursing workforce in Saudi Arabia are facing or currently facing. Shortage of Saudi nurses, which is very very significant because by 2030 the Saudi government needs to recruit 64,000 nurses, and the number of Saudi nurses compared to expat or non-Saudis is almost 40 to 45% of the nursing workforce, and this a challenge will affect patient safety in somehow. I'll discuss this point later. Because of the shortage, we do have high turnover. 20% based on studies, 20% turnover, which is affecting the cost of healthcare system. And the turnover is happening because poor work environment, long shifts, lack of career growth, and family unfriendly work policies. Because it is I would say Saudi context is very special. Number of nursing education programs that offer nursing programs in Saudi Arabia are not preparing a lot of nurses, and this comes to the shortage of nurse educators and facilities that needed to prepare students. Last, I would say workplace safety, heavy workload, lack of training opportunities, lack of structured career progression pathway, occupational hazards, including infection, stress, back injuries. All these challenges are facing the nursing workforce, and it affects the attraction, I would say, to the profession, and will influence patient safety in some way.
Yeah, Erlinda, do you see something similar in the Philippines?
Yeah. Hi. Yeah. I see something similar here in the Philippines. But before I go into that, let me just put a little bit into context. Now, what really the issues are, or what contributes to the seemingly nursing crisis that we have in the Philippines. We all know that the Philippines has been the #1 provider of nurses all over the world. I mean, mainly to the US. But the the recent developments seem to show that there is I would like to put it, quote unquote, shortage of nurses, because the nurses that we, again, I don't want to term it produce, but the graduates that we turn in and year out, basically, a great percentage of these graduates do not really end up at the bedside, but end up into more lucrative, quote unquote, lucrative work, such as being in call centers, BPOs, more economically driven types of works, no, that are more economically productive. Because we all know that, just like in other parts of the Asian workforce, that low salary continues to be the economic factor, becomes a driving force for our nurses to migrate to other countries. One of which is in Saudi Arabia, the European countries lately. Germany has been taking in a lot of nurses. Of course, the US continued to be the number one, but the last 2 months has been a no movement at all for the last 2 months. But that I would like to, and that's the context. That's the context whereby my country, our president is saying that you need to produce more because there is shortage of nurses, because the nurse-patient ratio is very high. I mean, even if the nurse-patient ratio law says that it should be, or the nursing law says that it should be 1:20 or lower than 1:6, it never happens. It never happens because of the lack of nurses. And this is where the irony comes in, because we're producing a lot of nurses, yet we don't find them where they are supposed to be. And so therefore, the challenge for the Philippine Nurses Association and organizations like in government and private is really to retain them in the Philippines and be where they are supposed to be. And that's where later on I would like to discuss some of the how do you call this, the strategies that we have been doing so that we can retain them and stay in the Philippines. Of course, the Philippines, just like any other Asian countries, Japan, South Korea, and other countries, there are also certain cultural factors that that we can attribute, to such, how do we say this, work-life balance also contributes one of the to the well-being of our nurses. We see that there seems to be not a very sound balance between work and family life. And well, we can say there are many factors contributing to this, and culture among them, gender-based differences between males and females, having expectations, being family members, Asian, taking care of intergenerational family members, how extended families are in the Philippines. You take care of your parents, you take care of, a single aunt or things like that. So all of this really, add up to the burnout and the well-being, aside from the economic factors that I have mentioned. There are actually many more factors, but at this stage, maybe I would like to allow my colleagues to add on to what has been said, and I'd love to add some more after the round has been done. Thank you very much, Allison.
Thanks. And John, we've had this conversation numerous times.
I know.
So what do you think, John, from your experience?
Yeah, so I would say very similar to the challenges elsewhere, at least from my experience speaking to nurses and doing research of, again, not being a nurse myself, there's a lot of structural challenges. So nurses' perception of not being supported emotionally by leadership, not having the staffing resources or the physical resources that they need to adequately take care of patients, what the textbook says should be the care plan. So there's a lot of disillusionment, I think, that can happen between what they learn in nursing school and then they hit a ward and it looks a lot different, and it can be upsetting or cause moral distress. And a lot of nurses are lost actually after that first year to either graduate programs or they choose to do something else entirely with their lives. We found in surveys, just as a side note, that about 30% of nurses are thinking about leaving healthcare entirely. So that's a huge strain on your workforce if, a third of folks are looking to do something completely different after training for years to do this particular job. Not different hospital, not different clinic, but not in healthcare. So I would say the structural issues are really at the fore. What hasn't been mentioned before is just a lot of, it's probably true other places that have electronic medical records, but a lot of the time nurses spend documenting the patient care versus taking care of the patients. So checking flow sheets and entering into the medical record, and that's time essentially important for billing and compliance and all of that and handoff, but it is not patient care at the bedside. And so there's a lot of that kind of time, which I think a lot of nurses feel takes away from their ability to adequately care for patients, just the sheer amount of documentation and care management coordination they have to do. And it was mentioned before, workplace violence is a concern. Most nurses that we surveyed indicated that they experienced verbal abuse. About a third indicated they experienced physical assault of some kind at work in the past year, which we published on. So that's a huge concern. And again, it does not make the job particularly appealing if that is the environment that you're representing to every day or, 3 or 4 times a week for, 12-hour shifts. And I also think just taking a big step back, maybe across the globe, particularly in the US, what we saw after COVID is that there was a mistrust of healthcare workers. And again, going into an environment where you might not feel supported by your leader, you might not have adequate resources, you might be verbally or physically assaulted, and your patients think that you're trying to murder them, is not a great environment particularly to be in. And again, it's not the case that everywhere is, those things, but those challenges can compound. I'm painting what might sound like a grand picture, but these are in total the challenges. It's not saying that every unit or every place is the same with all of these things at once.
Yeah, and I agree. And I hope everyone is seeing that there's so many common themes across what everyone is saying. We have a workforce supply and distribution kind of challenge where policies related to nursing education and licensure and funding for workforce development programs, that will in turn affect the supply of nurses entering the field and also their geographic distribution, right?
Yes.
We try to have policies related to loan forgiveness programs or maybe even incentives for rural or underserved area placements to really shape workforce availability. This is not always effective. There's still challenges with the distribution of nurses and where they're working as they tend to migrate more toward urban settings because the pay sometimes is higher. But in general, staffing and work conditions, regulations on nurse to patient ratios has been kind of a hot topic here in the US. The length of shifts and workplace safety issues, it's definitely going to impact nurses' workload and in turn subsequently have an impact on burnout levels and their intent to leave their job. But we do have to mention also that there's different layers of policy, right? So you have policy, enacted from the national or federal level, the state level, as we do in the US here, or the province level. But those policies don't always align. And sometimes state level scope of practice laws might dictate the level of independence for certain tiers of nurses, nurse practitioners, advanced practice nurses. And that affects access to care, particularly in primary care in underserved communities. So, policies on delegation and interdisciplinary collaboration, it really is going to impact a nurse's ability to provide that holistic and efficient and effective care that we've been trained to do. One of the topics that I increasingly have with colleagues is the lack of payment models that really identify the nurse's contributions to care delivery. Sometimes nursing tasks are invisible and they're folded within, the reimbursement and payment mechanisms. Here in the US, we don't have a central universal healthcare system. Without getting into details, we do have Medicare and Medicaid. We do have some form. We have the Department of Veteran Affairs. We do have some forms of a universal system, but it's not for everyone. So that value-based care system does influence how nurses are integrated into care teams and places really an emphasis on the roles that they play, how much autonomy they have, and then in turn on the patient outcomes. So now someone had mentioned, burnout is not strictly, and well-being is not strictly influenced by occupational policy, right? So well-being conceptually is the interplay of both the balance between home and work life. I'm curious, can any of you really describe some of the cultural factors or systemic differences in healthcare systems that really influence well-being in your region? Maybe there are male versus female differences, I heard, variation of health settings, or maybe, some more about that childcare and caretaking responsibilities or family.
Mm-hmm.
Erlinda, what do you think? You mentioned that.
Yeah, I think I did mention about the differences between in terms of the gender, because as I've said, in the Philippines it's very cultural. I mean, nursing continues to be, of course, female dominated, even if an increasing number of males getting into the nursing profession. It's still basically very female dominated, but at the same time, and female nurses, there is still that cultural expectation that when you get when there's a double burden of double shift. We call it a double shift because you have a shift from the hospital, and when you go home you also have a shift to do, take care of children, take care of the laundry, cooking, or I mean the taking care of the household. And time was when, and I could speak for myself with my own experiences, when we can afford to have household help to help ease the burden. But this kind of quote unquote luxury is getting rarer. It really becomes a privilege for those who have a higher income group. But nowadays it's really a double shift that you do, being a female. And usually, of course, there seemed to be an increasing gender sensitivity among the males, but not still to that level that males are more silent, and they're not as expressive still. No, the Asian culture, the Philippine culture still do not expect males to be very expressive, and so sometimes they suffer more. And I'm talking of male nurses, no? They don't normally talk about their feelings or what their experiences are, and sometimes this can lead to this prolonged or unresolved burdens or issues in the workplace, wherein you don't get to how do I say this? You don't get to process your feelings at workplace. So I think we've heard about emotional and compassion fatigue, this chronic exposure to suffering, and sometimes males get to experience this because they don't normally talk about it. So we have such a phenomenon called I heard this morning from the participants, unresolved grief, because they don't normally talk about it. And those are some of the gender differences. And I did mention also about those expectations that having to be an extended family, that you still take care of your parents, your aging parents. And for example, the younger ones now are left to take care of their parents. And this is actually the irony of things when Filipino nurses leave, no, leave for other countries. They take care of they take care of the elderly. They stay in nursing homes, but they back home they have their parents, their aging parents, and they cannot even take care of them. So things like this, and so the burden, also the burden, the emotional, how do I say this, their um guilt, no, the guilt feelings, especially for those who are migrant overseas workers, do feel about this particular kinds of grief, not only here in the Philippines. I don't know, Allison, if I answered the question that you were
Yeah, and
asking
it
me.
makes sense. And I think that's a common, within nursing and outside of nursing, we call that the sandwich generation because
Mm-hmm.
we're in between, caring for children, but also caring for parents and loved
Yeah,
ones. And
yeah.
and it bears a great burden. I think there's a great burden on informal caregivers that have their own
Mm-hmm.
careers and professions. And it's very, very challenging, I think, for not just nurses, but all health workforce. Um, when they're trying to balance that interplay between home life and work life and the responsibilities of your profession. Monirah, what do you think about the interplay
Uh,
between work life?
this is very, I would say, very sensitive issue when it comes to culture in Saudi Arabia. Although there are many changes that are happening because of the government initiatives to make the country more open and encouraging multinational workers to come and work here. However, nursing profession has it is specific characteristics when it comes to the Saudi culture. For example, or one of the challenges I would say facing nurses is the image of nursing. Many countries moved from this era. I would say post-pandemic, many changes has happened, or there is improvement in the image of nursing, but still, and I hear a lot from my students as as a graduate students, and they feel that they are still facing many challenges when it comes to the image and working in a mixed gender environment, away from their families for a long time. They have to be to balance between work hours and being at home, being with their kids, and studying sometimes. Male nurses, they face some challenges when it comes to working opportunities. Females are allowed to work everywhere. However, male are allowed mainly to work in male areas or provide care for male patients. And they, for example, they can't be trained in very specialized areas such as obstetric and gynecology. And this is very challenging for them. For example, if they work in ER and they have to deal with women in labor or something. One of the main challenges is cultural language barriers, which I would say international nurses or expat nurses are facing when they deal with patients who are not understanding their culture, their language, and also they don't understand the culture and they don't understand what patients need, for example, during death and dying or end of life care, or what does it mean when they need something, prayer, or they want to pray or ask for any religious things. I'd say family responsibilities and work-life balance, which is very essential and important because the culture is family oriented, and we are, as a woman, have to be at home providing care for children and for elders, and this is part of our religion, honestly. Like it is like important for us to be around our family, even especially when they get older. I would say multicultural workforce, and this would be a challenge for Saudi nurses because some of them have challenge to communicate with and understand non-Saudis, and this like we work with multinational nurses or international nurses, but again, for some people who are like having a limitation with their English skills, this would be a very challenging for them because they have to communicate with them. They have to document in English. They have to communicate even with Saudi healthcare care provider in English. And this is another challenge for, I would say, most of Saudi nurses. I mentioned the gender segregation policies. Hospitals are not gender segregated policy, but some units, for example, as I mentioned, special units for women, like obstetric gynecology, ICUs, doing some sensitive procedures. It is mainly for female nurses, and this will add a challenge for male nurses when they have to find an opportunity to work or they can provide care for patients in general.
Yeah. And John, you've done some work, in your center related to this balance. What's some of the research findings that you have seen?
Well, one that I was just thinking about as folks were talking is early on in the ratio maybe has improved a little bit, but it was mostly women seeking care in our center. If we look at all of the employees, at some point it was 70-30, the split of female to male identifying patients, roughly. I think it's come down a little bit, but I think male providers especially feel, particular stigma around seeking care. We're looking at that in particular. In some ways, I guess it's a double-edged sword in that nurses in general maybe are at greater risk of experiencing anxiety, depression. However, they are actually utilizing and are aware of services where maybe other professions or, other groups are not as much. So on the one hand, they're quite impacted. On the other hand, they're actually reaching out for help in general, which is good. I wish they weren't so impacted. I think what I will say is there are workplace factors and there are things just going on in the world. People have family history of depression, anxiety, PTSD that might raise the likelihood, given a set of stressors, that they develop, a mental health condition. It is partly about the workplace, but partly about, losses they have in their personal life, interpersonal challenges they might have, transitions they're going through, from new nurse coming onto a unit for the first time. That's disorienting. It may not have to do particularly with the work environment. And I think that's where, we emphasize that our center is actually for everyone, for every reason, essentially. You don't have to have a work complaint, or you didn't have to be impacted by COVID so directly at the very onset of our service, because we understand that things happen in people's lives, and actually, I'd probably say 50-50 in terms of what people talk about in our sessions is like work stuff versus personal life stuff. And the same patterns can often come up.
Mm-hmm.
That's something to keep in mind. Like there's both spheres are impacted.
Yeah, and sometimes it's not directly, sometimes it could be witnessing something. You can be a bystander to an event that becomes a stressor to someone. The word stigma keeps coming up in in this conversation, and I'm going to jump to that question for a moment. But there's a lot of kind of ethical dilemmas, I think, that are presented with nurses sometimes, and other health workforce. Sometimes organizations require mental health screenings and the personal disclosure of mental health history for licensure and employment in healthcare workforce. And this often raises significant ethical concerns, and I think contributes to stigma of seeking help in many ways. There's other issues related to privacy and confidentiality. Mental health history is personal medical information. So, should this be disclosed? Does this infringe on an individual's rights to privacy? Unless there's a clear job-related necessity, are such policies an invasion of privacy? There's a risk, I think, for discrimination and bias sometimes, and these screening policies can lead to discrimination, whether it's intentional or not, because there are some unjustified kind of barriers to employment or licensure, even if that individual is fully capable of functioning as a nurse, to the highest level. But then also you think about autonomy and fairness, and I think sometimes mental health conditions can vary widely in severity and impact. So requiring like this broad disclosure of a person's mental health history is really it might unfairly penalize individuals that have managed conditions while allowing others with untreated conditions to really go unnoticed. So I think that is a big deterrent to seeking help. And I think that contributes a lot, all healthcare workforce, the physicians we work with, our nursing peers, we're supposed to be strong, right? We are the caretakers and we have this role to play. But at the end of the day, everyone is human. And I think under certain stressors and trauma, coupled with things going on at home, things going on, policies at work, sometimes that can be the recipe where people really do need to reach out for help. So,
yeah, I can maybe just briefly comment on that. This has been, I think, speaking from other professions, it's been a really big challenge for physicians and advanced practice providers, onboarding for, credentialing committees at institutions. It sounds like same for nurses. I think just a shout out to the Lorna Breen Foundation, who did a lot of, and continuing to do a lot of national advocacy work to go literally state by state to say, hey, what is your state licensing credentialing question about mental health? And let's look at it. Has it been updated since 1935? And maybe we should have something a little bit more modern. And there's a difference between asking, have you ever had depression or anxiety, or something like, do you have a mental health or substance abuse related condition that could impair your patients? Something that's something similar to what we ask at Mount Sinai. But honestly, if you are in treatment for depression, the answer would be no, not yes. So I think people maybe see those questions and think, oh, I have to check yes. But I'm actually much more concerned, as you said, Allison, about a provider who has untreated, alcohol or substance misuse or depression or anxiety, than a provider who, again, we're human. Like 1 in 3 or 1 in 4 people in this country are going to experience a depressive episode at some point in their life. Are we saying those people shouldn't be doctors or nurses or other types of providers? That doesn't make any sense.
Erlinda, what do you think about stigma?
Alison, in the Philippines or in most Asian countries, where mental health is always equated with, if I were to say the local term, sira ulo, means crazy. So that's where the stigma is coming from. Like common people, when and they really do not understand. Even even those who are educated still would have that stigma. So they don't really talk about it. So even in workplaces, there are limited resources for mental health programs. I remember when I was the student affairs in the university, and I was fighting for a psychiatrist to be part of the health services office, because the mental health issues are just rising every day, and the administration wouldn't just hear me because of this concern. So there's still that stigma that goes around it. At the same time, that the resources are really limited, whether in the organization or in the or outside the organization. And there's a good case that came out earlier in the discussion in the conference, and this is a good good practice that is now in my city, whereby a mental health advocate presented to the mayor that why don't the city health office have a 2-hour mental health privilege that the employee choose a day where she would go home at 3 o'clock instead of 5 o'clock. So like it's a 2 hour. And the mayor appreciated it and said that it will not just be the health service office, the city health office that will avail of it, but we will open it to all government institution in the city. And that was one big gain that we had, because we see that there really is lack of support for those employees, no, having this problem. And so this includes now also our healthcare providers.
Right.
Yeah, so yes, indeed, mental health concerns here in this part of the region, this part of the world, still do carry such a strong stigma against it. Yeah.
Yeah, exactly. Monirah, you and I have talked a little bit about there's been some policies and practices implemented in your region to address
Yeah.
burnout and well-being. What do you think has been the most effective?
I would say, when it comes to work health and work environment, there are many issues, including violence, and what I really like and I appreciate honestly is the legal measure that was implemented 2 years ago, exactly I think post-pandemic, where the Ministry of Health initiated a policy or like a legal measure for any violence that happens toward any healthcare practitioners, including nurses, with a penalties of up to 10 years in prison and paying 1 million Saudi riyal, which is approximately 266,000 US dollars. The good thing that we are having now is access to health services through applications, including mental health support. Like I can go to an app where I can access any healthcare provider who has who is specialized with treating mental health disorders, and I can get support, I can get prescription without telling any personal information about myself. And this helped to protect my identity because, as you mentioned, and what mentioned previously, we have a strong stigma toward mental health. So having these virtual applications and access to virtual applications or apps that can be accessible at any time without mentioning any details would help with accessing support. However, I didn't find any study was exploring the mental health problems that are facing nurses. So yeah, studies assessing nurses' perception toward stigma or toward mental health disorder stigma, but there is no single study asking nurses, how do you feel? Are you okay? Yeah, there is satisfaction studies, there is turnover studies, but what about their mental health and how to protect their mental health and keep them in the health sector? This is something that we don't have, honestly. But maybe these, and I started honestly to hear that even with undergrad and postgrad students, that they are seeking mental health support. They are getting access to these applications where they can seek help without identifying their identity. So these are the initiatives that we have for now for Saudis, including nurses. However, stigma is still there, and no one will seek, like go to a clinic or when it comes, to get a medical report saying that you do have these problems, especially if you need to take special kind of medication that might affect your, like ability to work with patients. So yes, this is still an issue here, and but hopefully with the moves that we have or changes that are happening with the health system, more initiatives will come and improvements will happen to the nurses.
Yeah, absolutely. And you mentioned this role of remote application and technologies, and we see a trend here. We have a big Department of Biomedical Informatics here at Columbia. There is so much potential for the use of, I think, mobile technology to be able to capture not only to connect people to a mental health provider or get the treatment that they need, but also to better capture symptoms that might go unnoticed. Everyone is so driven to get their work done and their responsibilities done that not everyone practices that self-reflection, checking in with themselves, saying, "Wow, I'm actually meeting the criteria of a depressed mood or having severe anxiety." So some of the here at Columbia is we're trying to increase that amount of research and evidence that we have about mental health in nurses. And Monirah and Erlinda, you and I collaborated, I think, on one of the first international studies where we asked about depression and anxiety in nurses globally in the midst of COVID-19. And I think the research has only grown since then. Most recently, some of my studies, we're putting Oura rings on nurses and we're following them for months and months at a time to take away that subjectivity of surveys, but at the same time, really being able to capture that physiologic response to a stressor, to really show physiologic evidence to say, wow, physiologically, this stress level is elevated. There's a trigger. There's some type of stress dysregulation that in turn is precipitating a mental health risk in nurses.
Alison, let me before I forget about it, but it came back.
Yep.
Because we're looking at how we can detect using technology. But this particular sharing that an assistant chief nurse and a chief nurse mentioned earlier today, that we have not really maximized the traditional forms. There was actually a certain form of guilt feeling in one of because something happened, no, a nurse took away his life, and this was the only time that this particular the assistant chief nurse had to go back to the to there's apparently a test that they administer upon employment, and it seems like it was just like how something that's just done. I mean, that they did not really look into the data of this particular person. And so finally, when it was done, then that was the time they went back to and tried to look at the result of that exam, and it's too late. And indeed, the signs were there. And so the other one said that this is the reason now also that we are every nurse that leaves, unlike before that there were no exit interviews if they don't want to be interviewed, but this time we really make sure that they go through an exit interview and tell us exactly what they feel so that we can improve the situation. I'm just saying that there are, traditional ways of doing things, yet we have not been maximizing them. The data are there, but, I think we need to maximize this simple yet things that we've been doing in the past. I just wanted to say, because we're now looking at technology. Yes, I would also embrace technology to be able to, say this. But countries like the Philippines, and when you have limited resources, you don't even have enough nurses, supplies, etc. Having a technology to use this may not even be the top priority. So we need to rely really on procedures or strategies that can really identify these concerns of our health force or nurses. Yeah.
Yeah.
Sorry, I had to cut you there because it just
No,
came
that's
back to
fine.
me.
And I think you
Yeah.
you summed it up very nicely. And it's this really unique opportunity to the need for more evidence. And I'm seeing some comments in the chat. There is a tremendous need for more evidence specific to mental health and well-being of nursing workforce and other healthcare workforce. But once we have that evidence, we need to practice implementation and take it and have meaningful results where we can actually enact policy change to protect nurses, to build them up and give them the resources that they need to lead a healthier life. So just in the interest of time, because I do want to just give our attendees to the opportunity to ask questions, but I just want to close today and ask each of you if there was one policy change that you would recommend to promote well-being in nurses, among nurses in your region, what would be on that wish list? John, what do you think?
Yeah, so I would maybe go back to this credentialing question. Like really look at how mental health and the importance of that is messaged out to nurses, really at the licensing and hiring phase, but also how it's woven into, like we talk about trauma-informed leadership, which we train our leaders on, how we weave this into the everyday practice of nursing and how leaders can integrate an awareness that the work is tough and life is tough into policy to allow for folks to actually take care of themselves without being guilt tripped or feel like their job is on the line. So I think that really thinking about at a local level, how we can weave this understanding of well-being and mental health in a meaningful way into policy. It's not, sometimes it's easy to jump for quick fixes or like off-the-shelf solutions like, oh, do yoga, or here's an app you can have access to, or here's some pizza or a cookie, which I love a cookie. I love free ice cream, but that's not solving the systemic issues that require policy changes and investment of resources.
Yeah, I call that precision wellness because there is no one size fits all approach. Everyone has their own personal preferences about what works and what doesn't work for them for self-care, for coping, for stress reduction. So I think it is important that you bring up something really integral. When you are enacting policy, it can't be a one size fits all approach. It has
That's
to
right.
have, a multitude of different opportunities so that the nurse can then choose what works best for me. How much time do I have? And the other thing that you kind of touched upon, though, is, when policies or laws contradict an individual's morals or values, those consequences can be pretty profound. There's a lot of ethical and emotional distress when individuals, especially professionals like nurses, experience moral distress when required to follow policies that are not aligned with their own values. They believe they're unethical or harmful. This can lead to burnout and job dissatisfaction and emotional exhaustion. And sometimes you'll actually see nursing workforce refusing to comply with policies, which because of that interaction and that conflict, but that can result in disciplinary action or have legal consequences. And it's a very kind of delicate balance between being compliant with the policies in front of you, even though if it goes against, your training and what you need for yourself and for patient care. So it's interesting how that policies can really affect workplace morale, and nurses as a result can suffer when they feel their values are compromised. But I do think that history has shown that moral opposition to laws and policies often does lead to reform and progress over time. So I think that nursing advocacy, having a seat at the table, is of the utmost importance to really have great potential to influence policy change. Erlinda?
Yeah, I think I agree with your last statements, Allison, because for me, it's really putting the value where the value is. I mean, like, for example, the nurses in the Philippines or most in the Asian countries, I still see we're a huge group. The Philippines has produced over 1 million nurses all these years, almost 50% of which has left the country, and a great percentage also are not directly in the workforce. But we are a huge sector, yet our voices remain muted. Our voices remain to be unheard. Like, election is coming again, but why can't nurses use the voice to let the policymakers say, value us? We are the backbone of the health industry. There is that lack of voice. The nurse, like for example, the Philippine nursing law has already mentioned, and that was in 2002. It says that the salary grade of the nurse should be salary grade 15, which is about 40,000 pesos a month, for a government nurse. But that was only implemented after 18 years when the Supreme Court ruled that it should be given to a nurse. And it's in the law, but why do we still have to fight for it up to our last breath? That kind of thing, that why can it be given to, when it's really due us? So that value is something that has to be given by the powers that be, like,
Yeah,
they,
exactly.
I need, I need to be valued. We need to be valued. And you don't even have to ask for it, because the evidences are there that without the nurse, a health institution, a hospital, a health workforce is nothing. That kind of thing, Allison and colleagues, how do we, that to me is the greatest challenge. And if there is anything that has to be done, I guess it has to be it.
It does.
Did I answer your
I think it
question,
has
Allison?
begun, and I think the beauty of this profession, and I think you've seen this on this webinar today as we wrap up, nurses across the globe are faced with the same challenges, no matter what corner of the world you are working in. It is incredibly gratifying and empowering to think of how we all stand in solidarity with each other. We watch, as policies at the federal level, we know are having an impact on nurses globally. And we do need to come together and pull together and fight for that voice at the table, to make sure that we are taking care of ourselves, and at the same time, we're able to do the job that we set out to do, right? Everyone always says nursing is a calling. It's not just a profession, and we have to hold tightly onto that. I think that is one of the most important messages as we continue to navigate ever-changing policies, especially, here in the US, across the globe. So I thank you all for joining us today. I see Dr. Stone back on the call as well. We can talk about this topic for hours. And there's so many moving parts, but I'm so grateful to all of you. And I've loved the collaborations that we have had over the years. And I know there's so much more work to be done. So I'm really looking forward to that collaboration. So, and then on that note, if there's any last minute questions, but I'd just like to open up for any final remarks from panelists or attendees.
Sorry, I had to unmute myself. I want to thank everybody. This has been a wonderful webinar. There's a few questions in the Q&A, and certainly we don't have Africa represented. We know that nurses there are under stress. Certainly, it's clearly across the globe that we're seeing the stress in the healthcare systems or non-systems that we have, and we need to have our voice. I wanted to thank you all, and also let everybody know that we'll send out with your email. We'll put you on the Center for Health Policy list, so you'll find out what we're doing. You can always visit us on the website. We have like Health Policy 101 coming up next, so we have a lot of different topics that we like to try to bring to nurses. So thank you all, and appreciate it. And right in the chat, Bridget did put down where we're on LinkedIn, or you can visit our website. So thank you so much.
Thank you, everyone.